Thank you very much, Jonathan, for this marvelous and very kind presentation, and to you and Glory and all of you for the invitation to be here and to share some ideas with you about this issue of migration and health. And a little bit the background of this talk is also that there is a close relationship between our universities and University of Wisconsin-Madison and the University of Gießen in Hessen, in the federal state of Hessen, and so there are possibilities actually to collaborate, to exchange people, staff, students, and so on. And I hope that this talk will also be kind of a start of a closer relationship, and together with your Glory, there are already some interesting ideas. So thank you very much for the possibility to be here, and I now will share with you some ideas about the issue of migration and health, and I'm wearing two hats here at this moment. I represent the LANCET Commission, which is a huge honor for me to be part of this commission and have worked with all these incredible colleagues and to prepare this LANCET report on migration and health. And here's 4 copies, so if you are interested in having a hard copy, they are also available online. But I also will share some, in combination with the report, I will present some parts of it. I also would like to share some thoughts with you about what I learned in this process of preparing this report and my observations doing this kind of migration and health research, policy advice, and this kind of things on different levels and different regions and occasions in WHO with IOM and with the LANCET Commission. And only 2 weeks ago I was in Geneva for a 2-day expert meeting with WHO about the Global Action Plan on Migration and Health, which is now prepared to be for the World Health Assembly in May, and it was really a very interesting but also puzzling experience to see how migration and health is dealt with, or how many governments and many people don't want that, for example, WHO deals with this topic, and the opposition we meet when we talk about this issue, and the opposition I met in Germany talking about this issue. That's actually sometimes very puzzling, and as I am a physician but also a historian and an anthropologist, I'm doing participant observation. So I cannot do it differently than when I'm in these meetings to see what are they doing, why are they arguing this way and that way, and what are the larger issues behind, and I'm in a constant process of reflecting on what does it mean, what I see, especially regarding the human right to health and the possibility actually in our world to realize something like the human right to health. I know that the last Tuesday, Global Health Tuesday, was dedicated, or one of the last, to the human right to health, so you're all up to date on this, and I can probably, or hope that I can probably add some ideas at least on that, because I think we are in a difficult historical situation, not only in the States, with the president, some people don't even want to mention the name, and in Europe also, and I've seen that at WHO the strong opposition to address issues of equity, equality, and human rights and so on. I think it's really a critical moment in the history of human rights, and it's about us actually to work on this and to put this agenda forward against really strong difficulties. Okay, what I'm trying to do, and I'm looking on the clock a little bit, first 2 smaller statements to setting the scene about what we are talking, and then a brief overview on the LANCET Commission, where I use our official slides, or part of our official slides that we use to present the LANCET Commission in different places. I modified a little bit, but I'm very close to what is the official version of the LANCET Commission. And then the third part will be some observations about 3 critical points that I see in relation to migration and health. First, that I think that the migration in our developed and rich, wealthy countries actually is the litmus test of if we take human rights seriously or not, if we only talk about it or if we really show a commitment to this. And then what I see is now materializing in these debates about migration and health is the very old struggle in the health professions and the health sciences. How do we understand health? Is it for us only a technical issue that we approach in the lab with X-ray and so on, or how do we perceive and evaluate the social, structural, cultural, political dimension of health? And that's now again very strong to see, I think, in this current discussions. And then the last point is the process of making categories. It's probably an anthropological sensitivity that I saw in all these meetings, that directly the migrants, when we talk about migrant health, migration and health, people start, well, about what type of migration and migrants do we talk, and then we create categories. And I have the impression that this categorization is also a process of undermining human rights, because the majority of categories are built to reduce entitlements, to manage migration, and not to support the people behind it. It's kind of a process of forgetting of forgetting that we are dealing with human beings, but to think and to enable us to think in a more cold and more rational, probably, way with the issue, but easily to forget that we are dealing with migrants, with human beings, and that's the final point I will make, and then some final conclusions regarding the political determinants of health. Okay, I will start with this first quote, which is from the front page of the Lancet report, and I like it very much. Worldwide mobility is our future, regardless of laws and walls. And that's a very important statement. I'm very happy that the Lancet actually has the courage to put this statement on the front page of the journal. And this is a point that reminds me a little bit of the issue of climate change also, because many politicians, many people don't want to talk about this, about climate change, about migration. They say, no, it's not true, or it's only a crisis, it's only a moment where we see a crisis. We used to talk in Europe about the migration crisis, and that's also actually a problem, because it also suggests a perspective on that as if it would only a thing that can be solved, and as if it would not be a part of human societies at large, and always in history and in the future that migration is happening. And so it's a very strong statement, and shows also that we always have to argue against people who say, no, migration is not a normal issue, but it's only an exceptional issue in our societies. And that we can control migration and migrant flows with laws and walls. And that's the thing we are working actually against when we talk about health. Because all these laws and walls at the end have health consequences, and detrimental health consequences for the people concerned. And that's also a point that we as scientists probably have to make visible and show in our research. And with the Lancet Commission, we tried at least to do that a little bit, to show that these politics meant to control migration often have really risk for the health of the people and our societies at large. And then I like, as a positive point of view, very much this quote of William Lancey Swing. He was the Director General of the International Organization of Migration until recently, saying that migration is not a problem to be solved, but in reality to be managed. And that's a very important statement, so that we don't see it only as a problem, it's a normal reality actually, and it's also always usually a chance for people. And Laurie reminded me very much that migration also always is related with hope for the people who migrate, with hope for a better future for themselves or for their families and so on. So it's not only a problem, but we are used now to have a rather problematic view about migration. And that's a shift in the perspective, which is really a problem. And so it's not a problem to be solved, but a reality to be managed. We have to manage migration actually, and states have the obligation to manage migration, but bearing in mind that we are dealing with human beings, entitled with all the human rights, and that a good management is better for all, both for the migrants and also for the other part of society who in that moment don't migrate. And probably the person who now is not a migrant can be, for what reason, be a migrant in the future without knowing it today. So it's actually an issue which is relevant for all of us, and we have to make this visible. So that was for putting a little bit the scene, and that's the report. We call it, I think it was Ibrahim Abu Bakr, the head of the chair of the commission, a colleague from London, the director of the Global Health Center at the University College London. He coined the title that it's the health of a world on the move, and it was a group, a rather large group of authors, and managed all by Ibrahim Abu Bakr, and he actually did a great job. I admire him very much, and also the writing team with Rob Aldridge, with Dylan Lebukma, and Miriam Orkut in London, trying to organize this large and very heterogeneous group of people and to make a consensus paper of it. And sometimes I was reminded of the quote I found in the records of WHO history from the 70s in the Alma Ata process, one saying that we'll be trying to get a paper done by a large group of people. And it was a kind of a quote saying that a camel is a horse designed by a committee. And that is also happening with this report sometimes, that we want to make a coherent and fine paper. At the end it was not that the perfect horse, it was more like a rare horse, like a camel, and that was a process, but it's an interesting process, and we all were part of it, and it was really a great experience. And the context of this first was a statement by Richard Horton from the Lancet, and Ibrahim they made, and saying, well, migration is a global reality and we have to face it, and one number that we have now 1 billion people on the move in 2018, but the majority of global migration occurs within low-income and middle-income countries and not in the wealthy countries of the north, even though the international awareness for the migration issue only started actually in the years after the big migration crisis in 2014-15 with Syria, and because then it affected the wealthy countries of Europe mainly, so there was much more international awareness for that. And then putting the context of the report is directly a political concern actually about the populist discourses that demonize migrants, and saying at the same time, and that's part of the report, these are the people who uphold our economy and bolster our social services and contribute to the health services in both origin and destination locations. You can see here in this official statement of the report that we always try to shift the perspective from the negative, from the concerns to the positive, but without only being kind of naive and saying it would everything would be fine. No, that actually there are problems and so on. But it was an attempt to change a little bit perspective. And then the concerns about those in power continuing to restrict or publicly condemn migration to promote their own interest. And we have seen it here, we have seen it in Europe, and that's the context of this report. And the purpose of the Commission was to build a large group of authors, in total 46 authors from over 20 global institutions from all over the world, and it was an interesting group, and they convened in 2016 to get an overview about what do we know about migration and health. What is the evidence that we have, and with this evidence inform public discourse. I entered a little bit later, so after the first meeting I was not present, then I was asked by Ibrahim to join, because for the issue of social cultural issues, as with my anthropological perspective and a little bit historical perspective, and then for the human rights perspective. So that was mainly my area of work. I was not working on the epidemiological issues and so on. So we had different working groups and prepared parts, and then they were put together, and then we had a larger meeting 1 week to bring this all together, and we had about 3 times the paper that was published later, and so it had to be reduced. It was a very interesting camel designing process. And we had working groups to analyze different topics and to consider the evidence we found, and it was with people from sociology, political science, public health science, law, humanitarianism, and anthropology, so it was a really wide spectrum of professions joined there, and it was a very interesting process. So the aim of the Commission and of the report was to provide the latest evidence on migration and health outcomes, which is a critical issue, and we have seen that these evidence challenge some of the common myths. I have later examples for that, and highlight the diversity and dynamics and benefits of modern migration and how it relates to population and individual health. And the basic message I have put in red here is that migrants generally contribute more to the wealth of the host societies than they cost. And you see it's an argument based on our research and of gathering information from all over the world, put into a nutshell sentence to give this to the political discourse. And that was our task, actually. So it was a very political endeavor. And that was the point that I was very much interested in, to examine the multi-sector determinants of health and consider the implications of the current sector siloed approach, so that we have different areas, migration law, we have health, we have education, and so on, and we don't have a coherent perspective on them. And that all these different areas that are dealt with, usually from different experts separately, have to see together, really, to have a coherent approach, even for migrant health. And what I would highlight here is that the health of people who migrate depends greatly on structural and political factors that determine the impetus for migration, the conditions of the journey, and their destination. And that's also an interesting point I want to highlight when we think about migration and health. Many researchers or people interested in this topic look only, well, here we have the migrants, and then we will want to see what are the health risks, what are the epidemiological patterns, and so on. But only at a particular moment in time, and without looking the histories and the factors behind it. And it was suggested already before in the literature, and we developed it a little bit further, this model to understand the context between the relationship between migration and health, looking on all the phases of the migration process. And so we start looking on the origin, what is happening in the origin, what are the determinants of health at that time, what is the predispositions, for example, for diseases, and so on, the social status of the people before leaving their country. And then we distinguish different phases of different ways of the migration process. So the short-term transit, the interception period, or longer-term transit. And short-term is when a migrant goes on a plane and arrives the next day in the country where he wants, in the destination country. Then we have the long-term transit and living in Germany, and we in Gießen have one of the largest reception centers for migrants, for refugees in Germany and our city. And well, I know patients who came from Somalia, they have traveled half a year or a year, or have been sitting and waiting in Libya in these camps that are actually, they were described by the German Foreign Service as concentration camps. So Germans use this name, and Germans don't use this name easily to talk about concentration camps. And or from Syria, some people came in a few weeks, others really traveled walking or in wheelchair, months to arrive. And so this long-term transit makes something with the people. It has, entails lots of risk for the health of the people. And then we have this category of, or this moment of inception, or this transit situation, which often is not a transit situation, but they get stuck. Interception is from international law. I think you may understand it better than me, where English is my foreign language. But interception is when a boat gets caught on the way before arriving to a place. And we have there was a paradigmatic policy for this notion in Australia. They don't permit the refugees going on land in Australia, but they keep them on islands in the Pacific under disastrous conditions. And some physicians did research, and then they got prohibited in Australia to talk about that, and it was really a scandal in Australia. And even the United Nations have informed that, or made some reports about this incredibly harsh and living conditions of migrants in this island in the Pacific, without a possibility to go forward, cannot go back. They are completely out of any possibility to move on, and no agency, no possibility to thrive. And this interception period is very important and makes something with people. And we see it now in Europe, for example, and in the shores of Europe, in Greece and Turkey and Libya, where people are caught and they cannot go on, cannot go back. I have been 3 weeks ago, a month ago, I have been in Lebanon in the Bekaa Valley, which is really close to the Syrian border. and I saw there the informal tented settlement of refugees from Syria, mainly women with their kids and adolescents, because then the fathers are or died in Syria, or are in prison, or tried to go to Europe, or probably in Spain, or in Sweden, or in Germany, and trying to get their families home. But it's bad to them, but it's very difficult, this family unification now. And it's probably 1 million of people there. They cannot go north, because there is Turkey, then they can't go to the Mediterranean, they cannot go south, they cannot go back to Syria, and they are there. And they will be there for 1, 2, 10, 15, 20 years probably, without schooling, without healthcare. And UNHCR, they don't cover all the needs of all the people. They're completely underfunded and have not access to all these people. So they are in a situation of kind of an interception, not defined by a government. Who says we want this situation, but only the governments, all the governments say we don't want them. The Lebanese government does not want them, the Syrian government does not want them back, Israel will not let them enter, Turkey not either. So where do these people go? What will happen with these people, with these children in the next years and decades? And that's really a very tough issue, and has to be addressed seriously. And then also the situation in the destination countries, and some people return. So in all these phases we have some risks for health. And there's one example I'm working with in Germany. We have seen that we have rising number of TB patients in Germany. We have still a very low rate of TB in Germany, but the numbers are rising slightly, and that's the interesting point, more than 70% of the cases are foreign-born and refugees. And you can imagine what this means when you say this to the press. Yes, the majority of TB cases are refugees. Directly, the refugees bring tuberculosis to Germany. It was eradicated, now with the refugees it goes back. But that's not that easy. So it's people from countries like Somalia where tuberculosis is strong, but it's not that they are bringing, because we see that the risk for people from Somalia, from Eritrea, even from Syria, to acquire tuberculosis is much higher in Germany than in their own countries. So they are acquiring tuberculosis on the way or in Germany, and they don't bring it, but it's the conditions of their migration process. And so that is a crucial question, and I had large conversations with journalists about that. It's really difficult actually to transmit this message in a coherent way. And so we can see in the phase of origin, are the people healthy or not? And usually people who leave the country are healthy, because people who are unhealthy cannot make their way. Well, in Syria it was different, because it was actually an emergency to leave. But even from the refugee camps in Lebanon and Jordan, the people who went to Germany later, it was more the people able to leave, because if you are unhealthy, you cannot make this journey so easily. But probably some of them had latent tuberculosis. And when they are well nourished, when they are in a well situation, they will not develop tuberculosis. But when they are in a crisis situation, when the living conditions, the nutrition status gets worse, latent tuberculosis can convert into an active tuberculosis. So the conditions define. Then we have the transit, and we have these living conditions I mentioned already in Sudan and Libya and all around Central Europe. And there are accounts of the conditions for Somali people living in Italy, for example. Many enter through Italy because it's geography, and they have no rights for nothing. So they're living in the streets, in abandoned houses, very close together, and that's the best conditions for tuberculosis to thrive. Not for the people, but for tuberculosis. And then we have in the destination country, a very rich country like Germany, isn't able to manage tuberculosis care for migrants well, because the system is not used to do it anymore, because tuberculosis is forgotten, because it's very complicated between the hospital and the general physician and the different administrative institutions involved and so on, and because nobody actually wants to take care of these patients. And we see really high numbers of treatment dropouts in Germany, even though we have one of the best health systems in the world, but the people don't care, and the structural barriers are so high. So all these factors provide for this higher number of tuberculosis in Germany. And you cannot say they bring it to Germany, but it's actually the migration process at large. And that only as an example. And then what we did, we critically reviewed key challenges to healthy migration and show that the mobility of populations provide at the end economic, social and cultural dividends for those who migrate and the host communities. But one of the key challenges is that that is not seen, but mainly politicians see the security concerns that even raise them more. Again, this political context. And then we examined, as a commission, the equity and access to health and health service and the need for evidence-based solutions to improve the health of migrants. And the key message, which is also controversial in Germany, where we have a very well-developed health system, but refugees and other groups of migrants are excluded. So we have not only universal health coverage for all migrants in Germany, and it's really a tough discussion with politicians about that issue. They really don't want to accept that. And then they say, well, but Germany is not worse than other countries. And so they find some kind of argument to justify. And the myths that we identified, or that were identified by the Commission, and that later in the public communication after the launch of the report, the Lancet focused very much on this issue that there are these myths about migration and the evidence does not support them. That was the main message for the public communication, and it really worked out. I was skeptical actually. I thought it's too superficial and not scientific enough, but it's actually worked out in public communication to raise awareness and to get our message under the people. So, for example, are high-income countries being overwhelmed by migration? One of these myths we could show, and studies show that's not the case. Are migrants damaging economies? No. Are migrants a burden on health services? And we have shown that it's not the case, not for the patient, and on the other hand, that migrants really run our health systems. In UK, in Germany, we could not have our health system as it is without migrant workers. And if migrants are disease carriers that pose a risk to the resident population, and that's one of the old stereotypes of infectious epidemiology. And I know there are historical accounts of that even from the farthest times. So in Germany, for example, syphilis in the 70s, 80th century was called the French disease. So it was syphilis can only be the France. So because our enemy, and when he comes, he brings us syphilis. That's the same level of argument. And then, do migrants have higher fertility rates than among host populations? And they are concerned that we have this overburden of now migrant communities in Germany, and that Germany will become overwhelmed by the population bomb brought by the migrants. And there's no evidence on a general scale, even though we know that I learned yesterday about the Germans in Wisconsin having in the 19th century an average of 12 or 13 children per family. So that was probably among the German migrants is probably the case. And I'm from a family with 6 siblings, so the Germans are very fertile, so it's a problem for the world probably. But in general, you cannot say that migrants have the higher fertility rates. It depends very much on the context and so on. But it's one of the issues discussed, and so we put these statements in the front. And now I turn to the key messages of the report, and then I come to my observation. I think I have still 10 minutes, okay? That's fine. So the message are, and you see again, very calling for action. We call on nation states, multilateral agency, non-governmental organization, and civil society to positively and effectively address the health of migrants, not only negatively, and by improving leadership and accountability. And we have some case studies that really the leadership, both on a national level, like in a certain moment in time in Germany with Angela Merkel, was very strong leadership. Later it was not that strong anymore. But political leadership, but also we see that in Swiss, for example, there was on the lower level of a health ministry political leadership to open the health system for migrant sensitive services, and they achieved a lot. But then it was a problem of the local leadership and the leadership of the hospitals. When the head of a hospital does not subscribe to this idea and fails in his or her leadership, then even a national policy will fail. So it's actually an issue of high and middle and lower level leadership to get these things done, and accountability, which is a very important issue. And then the point, which I also find very interesting, that international regional bodies like European Union and the United Nations should rebalance policy making in migration to give greater prominence to health by inviting health representatives to policy making forums on migration. I was thinking that's normal when it's about migration and health in the level of United Nations or European Union or state governments, that health people would be invited. But I learned now in Geneva, and they said it explicitly, that the majority of the decisions in the UN about migration, the health ministries are not invited, even when it deals with health issues. It's for the internal Ministry of Internal Affairs and external affairs and so on. But the health, even the health politicians are marginalized in the political decision-making process. And the people in WHO are very much aware of that and suffering with this. And they also call for a stronger recognition of this field. The second message, on the second slide, this message is with the third message, that we have to address racism and prejudice much more clearly and with a zero tolerance approach to this, also in the health sector, but also that's a responsibility of public leaders actually to show leadership against racism and not what they are doing in part today to improve, to foster racism and prejudice. And then that universal and equitable access to health services and to all the determinants of the highest attainable standard of health need to be provided by governments to migrant populations regardless of age, gender, legal status. And we repeated and repeated and repeated this non-discrimination. Sometimes I was getting tired of this, also in the discussions in Geneva. Or I sometimes think, well, we have the Universal Declaration of Human Rights, we have the basic legal instrument, international legal instruments on human rights, where no discrimination is included. So why do we have to repeat it all the time and all the time and all the time, especially regarding legal status, which for me is one of these ways and categories or avenues, or however you might call it, for this discrimination becoming introduced in political discourse, into institutional behavior, and so on. And even talking with physicians, they sometimes feel it's not okay, they don't have the entitlement because they are this kind of migrants. And it's apparently that the legal status also for healthcare providers, for many people, is a very convincing argument that a person has lower entitlements to human rights and does not have the right to have rights in terms of Hannah Arendt like other people. So for me, the legal status, legal categories are really a problem for achieving health for all. And I was discussing this kind of hardly with some lawyers who say, no, legal categories are legal categories. They have no other function than define legal entitlement and so on, and they don't have this social or even health impact. And that's for me one of the basic discussions also. And then moving forward, the Commission argues for a paradigm shift in research on migration and health, with a deliberate effort to enhance the founding mechanism and the network supporting this change. So we need more research, but that's not a surprise that researchers say we need more research because we have funds. So that's at the first glance not a surprise, but it shows that we have actually a need for more evidence in many areas. So we have to improve the research, and we need a strong partnership between academia, policy, and frontline health and humanitarian workers. Even though I think we need partnership with policies, but I think academia and civil society are here on one side, and politicians are often on the other side. And so the academia and civil society and humanitarian workers have to work together to convince or put pressure on politicians. And then the news now is that the Commission will be continued, like the one on the work of the Lancet on climate change. And the second one from the Lancet Commissions to be continued is actually now the one on migrant and health, inspired a little bit by the work of the Lancet and the Commission on Migration and Environmental Health and the Lancet Countdown and so on, to continue observing future developments, to give input into the discussion and to reporting about achievements and about setbacks. So there will be probably on the World Health Assembly in May event to create this new Lancet migration standing commission. That was a little bit an outlook on the report, and now I have a few minutes for my observations. Only 3 slides, so 4, so we are close to finishing. And it's rather put here explicitly personal. So I'm not speaking for the Commission, and the Commission is not a homogeneous group, and I'm in a constant communication also with Ibrahim Abu Bakr and other colleagues, but it's actually my point of view, and that's my intermediate thinkings, and I hope to advance this a little bit further with you because I'm there in the constant process of thinking and rethinking. Well, the one is that it's probably easy, that migration is the litmus test for our wealthy societies and democratic societies who officially identify with human rights, who even do interventions, military intervention in other countries to defend human rights. So human rights are really a heavy political argument for our politicians sometimes, but not necessarily at home. And I had the privilege to talk with Angela Merkel on this issue, not to talk with her, but there was a meeting in Germany of the Migration and Health Summit, or Migration and Integration and Health Summit, and I had 3 minutes among a large group of people, and ministries of all kind, and many people from civil society and so on. And I asked, or I said that I'm wondering why Germany, which is a country who really supports other countries about the human right to health, we have an explicit strategy from the German government for migration and human rights, but only in development cooperation. So Germans, experts from the government go to Kenya, to Cambodia, to other countries to explain to people how to develop a human rights-based approach to health. And I was asking Angela Merkel that I'm wondering why we don't use this knowledge for our internal affairs and for our migration politics now, 2017, in Germany. And she looked at me and saying, "Oh, that's a good idea." As if she would have heard of this the first time ever. But I know that a few months ago she opened the World Health Assembly in Geneva talking about human rights to health, but only thinking in Sierra Leone post-Ebola and this kind of things, and never getting the idea that it could be relevant for Germany. And I find this in lots of occasions talking to people in Germany about the human rights to health, and even diplomats and lawyers said to me, that's not a real human right, and only for other countries. In Germany we are better than other countries. So there's kind of the notion that we don't have to address our domestic issues from a human rights perspective. But now we have the migration issue, and we have it not only now, we have it since many years. And so reflecting on Europe's attitude and policy regarding migrants since many, many years, and already previous to 2015, what are we doing in Europe? Are we actually complying with human rights or not, as we usually say? And the first was made me thinking in this way was this image from Ceuta. It's one of these Spanish enclaves in Morocco, where many people from Morocco try to enter, to come to Spain. And you see here the golf court from Ceuta, funded by the European Union Social Fund. And here is a fence funded by the European Frontex border institution. I don't know which was the European funder. But you see here the Europeans playing golf, and there you see the people in this fence, which is really a fence that reminds me very much of the inter-German border, the wall, with all these very drastic measures to keep people away, and where many people trying to get over, get hurt, or die, and on the intended. So, and with this experience, I have been in Athens and Greece in this time, and so I was really thinking, what is doing Europe here, and where's our human rights identity? And so, that made me think very much. And then I looked back and reading about the history of human rights and looking back to the early years of the modern human rights discussion. When you look at the 1947, 1948 on the work of Eleanor Roosevelt, for example, when they were drafting the Universal Declaration of Human Rights, the government always already opposed the idea of kind of accountability, limits of sovereignty, and so on. The government already at that time showed reluctance to accept that there is a different authority to control them, what they are doing with minorities, with people. But it was a historical moment where it was possible at least to draft and to get it done, the Universal Declaration of Human Rights, but also only because it was not binding, but only a declaration. But so the reluctance of states to admit something like rights for the undesired in the society, rights for these people we don't want, we don't recognize that human beings sometimes, if you think on Sinti Roma and so on in Europe, and to accept external control and limit of sovereignty was always a problem for the governments. And so it's actually not a surprise what I've been seeing in all these meetings with governments and so on, to see that human rights are always an imposition to governments or on governments and on the duty bearers, and they actually don't like it. And we must not be surprised that governments don't support human rights when it's about their own duties. So, on the one hand we have the governments, and on the other hand, on the other side there's civil society and academia, and some lawyers, and the legal system and the international legal system. And among the politicians there are also some people who really want to join us and are supportive for that, but in general the duty bearers always have to do something what they don't want to do. So always when we talk about human rights, also when we talk about human rights to health, we are automatically political and challenging the government. And this, for example, was in Geneva the case. So we were asked to develop a document that was not political, was able to have political consensus among all the member states. But it's impossible. You cannot talk about human rights and get consensus by member states. That's a contradiction, because only when you have member states and governments who are really enlightened and really want to put the human rights agenda further, especially at home. But that's really difficult to achieve, and I think that governments always need the support from civil society, and support can be something like the LANCET, information, evidence, and also kind of pressure and public calling attention and activism. So you cannot advance the human rights agenda in health without being political, I think, and without challenging those in power. Second is the ongoing struggle between technical and social concepts of health. So the history of social medicine and shows that there's a kind of a continuous marginalization of comprehensive approaches to health since the late 19th century. So always modern medicine tended to be technical, to advance research in the lab and so on, and to marginalize approaches and people who had a more political, social, cultural, anthropological perspective on that. And we had some exceptions like the Amato process in the 70s, but it was also very fast stopped by the other way of understanding, not only by external forces, but also by physicians who did not subscribe to this social and comprehensive approach to health. And in the discussions in Geneva, it was also incredible to see that we have always been asked to make a technical report and not to become political, not to talk about social determinants, and not to have this comprehensive understanding. And that's, I think, one of the basic struggles in health, and especially related to human rights approaches to health, that we need this broad approach. And so I think that the human rights approach to health is not only in the migrant issue, but in general is undermined by all these rather technical approaches to health. We need lab science, we need technical approaches, we need numbers and so on. But that's not all, actually. And when we think about universal health coverage, it's meant to be universal, but when we are happy with improving from 70 to 80% of coverage, that's not universal. And when people say to me, well, these groups are difficult to reach, so now we will focus on those better to reach, on the lower hanging fruits, that's not human rights, that's not universal. And especially in the discussions about universal health coverage, and especially related to migrants, the issue of equity and universality is sometimes absent and covered by the success of raising numbers from 70 to 80 or 80 to 90%. But universal means 100%. And that's demanding and challenging. And this comprehensive approach is thus very demanding also for our medical system to accept that there's other forms of evidence, historical evidence, anthropological evidence, qualitative evidence, which is important in healthcare. Not only numbers, not only lab science and this kind of things. That is not to say that numbers and lab science are not important. It's fascinating and very important, but we also need this other dimension. And then the issue of categorizing, I already mentioned it a little bit. So we use categories to distinguish and group migrants according to legal, administrative, research and other purposes. So every category has a purpose. But then they develop a life on their own. They are there. But they are not objective or natural. They are made by people according to a logic, and one of the most famous discussion about that is about the Geneva Convention of Refugees, and if climate refugees, for example, are refugees according to the convention. With the convention, falling under the convention, they have benefits. They have better protection of their rights and so on. If they are not under the convention, they have lower entitlements. So we have their hierarchy of the migrants. And the question is if we can develop the Geneva Convention further to be more comprehensive, but we have huge opposition from many sides. And also the subjective perspective of the individuals is actually not reflected by this categories, which is also very important. And the problem, as I see, is that these categories are used as if they would be natural and self-explained, but they are not. And that they create hierarchies among migrants, and they create social spaces with really reduced legal entitlements. But these spaces are largely accepted by the majority of people because we don't think about them. I think these categories seem to be so convincing to us because they are legal probably, and that we forget the impact they have. And I think that individuals often lose their right to have rights, what Hannah Arendt describes. So they have not the right to have all the rights of human beings, and because they are only undocumented migrants. And that's a very practical issue in the States, I think, and in Germany and many other places. So I'm finishing now with these 3 points regarding the political determinants of health of the world on the move. We have seen that the Lancet Commission is a profoundly political endeavor and was strongly criticized for that. And I had also some experience in Germany with not so kind reactions about what I'm doing, but that's part of the movie. But it's an important contribution to advance the political determinants of health agenda further. And I find it very important to talk about political determinants of health because it's social, legal issues. They are all results of political decision makings, and we have to make this visible by our research. I think the Commission report is not perfect in this. Sometimes I think that you can read it as a way that we start with political arguments that we are against populism, for example, and then write the medical stuff. But I think we can start actually with the medical stuff. It's a question, what makes people healthy or what makes people sick? And then follow the determinants for migrants and for not migrants and for all human beings. And then we see that political decisions at the end define who has a chance to get sick or not. On the local, on the national, and on the international level. And I think this Migration Commission is a contribution, but we are still on the way to keep this developing further. Thank you very much.
Well, thank you, Mike, and it's your talk is so timely, especially well all over the world, but our country, the people that don't have access to health, and then the shunning of the political rhetoric around migrants. It's just spot on for us. So, any questions? We have a few minutes for questions from anyone. Laura?
To what extent were the voices of refugees themselves taken into account in the process?
Not directly, but we had several people working on the ground with refugees, so that we reflected it, and it was, but they were not in the process directly involved. And we had, besides of the authors, we had also other contributing people in the group who are very close related, had their own, well, we had also people with, well, we had one actually with a colleague from American University of Beirut. He's from Aleppo, so he had to leave Aleppo and is now in Beirut, so he had lived everything. And so we had people, yes, but he was selected because of his academic achievements, but he has his biography. And we had lots of people with migration background in the group, and if you ask many people all around the place, you always find more people with migration background than you suspect. I also have a kind of migration background, even though it's not probably visible.
Thanks for your talk. I'm curious, those myths that you mentioned, the myths that you dispelled in the report, talking about the spread of disease and whatnot. Has there been an effort to, other than the report itself, to get that information really more widespread? Because I think there are a lot of myths here about immigrants taking people's jobs or sucking on social safety nets and not contributing to the economy, which we probably in this room know not to be true, but a lot of people believe those myths. So I'm just wondering about the kind of communication plan to...
Well, it was a huge communication effort. And with Twitter, with social media, with short messaging, and so on. We had also regional launches. So it was first launched, the report on the summit in Marrakesh for the Global Compact on Migration in December. Then there was one in New York, and one in Germany, and one in Lebanon, and one in South Africa. The next one will be in Peru. So there are intents actually, and my colleagues, I'm not that much on the social media, but some of my colleagues are very active on that. And the press covered it really largely in many countries. So in Germany, for example, it was for 2 days it was a topic, but then it was again over. So we have to insist, and I think it's not only the public communication, but also to use this for training, for example, for education in our universities. So, and not only the superficial issue of the myths, but also going deeper and about the determinants and so on. I think it's a task for education especially.
So our expert in migration, one of our experts who works a lot with migration.
Well, thank you for your talk. It was really enlightening. And I'm just wondering if there's a research agenda that has been laid out, or any plan, or...
There are recommendations for research, but very comprehensive. But I think we are now in the process of, as a commission, defining what will be our research proposals for the future. But I think the report gives kind of an overview about this, some of the necessities, but I think not comprehensively actually. So as a personal note, I would have loved to have a stronger call on anthropological research and critical research regarding what I said about the social dimension, social dynamics of categorizing and of exclusion and so on.
Great. So,
I have a question.
First
country?
lady.
Yeah, oh, sorry.
First lady, our Peruvian First Lady is here, Nancy Lang.
Former First Lady.
Former First Lady. Nancy,
Uh,
you get the last question.
Oh, so what country do you think does the best job in dealing with migration?
Good question. For a time, I hope Peru would do it.
Well, we did allow Venezuelans to enter Peru starting 3 years ago. If they could manage to get to Peru, they were allowed to stay. And something like 600,000 Venezuelans are in Peru. And I'm not exactly sure if they can enter the public health system, but I assume they can, because any Peruvian can. Not that it is necessarily a good experience, but there is some level of basic care. But what country do you think does the best
Well, that's a really tough question. I think Switzerland has a very well developed migration and health strategy, actually, but they have a very restrictive policy of letting people in. And Germany has had a time where we have accepted many people, about 1 million or so of refugees coming to Germany, but the health system is good, but there are these legal administrative barriers. In the MIPEX report, which was an intent to categorize or to analyze the migration health policies of different countries, about 40 countries, European countries, but also the States and Australia, the United States looked very well, but it was before the current administration, and it's difficult because it's difficult to measure a country because we have different areas of migration and health politics. You have for the legal migrants, for the undocumented, for the refugees, and so on. And some countries are in some area very well, and the other very bad. So it's difficult. But we see that countries who have been advanced, like Germany, like Sweden, are now turning to politics that are much more restrictive. And France has a very open public health system. Great Britain was really well until about 5 or 6 or 7 years. Now they are really, really reluctant. Spain was very good. I think in Spain still Catalonia and Andalusia are really well, but other communities are much more closed. So it's not a coherent picture. And the one guy in WHO also said, for us it's very difficult. We have one member state sometimes has 3 or 4 different voices. We have the voice from the health people, from the prime minister or the head of government. We have the voice of the foreign ministry, of the immigration people, and so it's very difficult. We have no country with a coherent politics, with a coherent policy actually.
Yeah, great question and great insight. So time is up, so why don't you just help me thank Dr. Knipper.